Good morning. Welcome. I'm so pleased to be here today to teach you about emergency care of the pregnant woman. My name is Barbara Files. I'm a certified nurse midwife. I've been working in the trenches with childbearing families and catching babies for almost 30 years now. Today's focus is going to be on imminent delivery and some of the complications that you may encounter in the field. Today, all our babies will come out head first. They'll be pink, they'll be vigorous, and we will save neonatal resuscitation for another day. The key concepts that we cover today will apply to care of any pregnant woman in any setting, whether it's trauma or another sort of complication of pregnancy. Also topics for another day. Pregnant women are not like your other patients. Pregnant women are different. And what I want you to take home today are 4 concepts. Pregnancy touches every cell in the body. There are alterations in maternal anatomy and maternal physiology that will make your assessments a challenge. The pregnant woman has a different response to shock. She has unique injuries that can occur. She has a uterus that is large and out front. She has a brand new organ that other patients don't have, a placenta. And in caring for pregnant women, you will be able to see, touch, and hear only one of your patients when in fact you have 2 patients. So what do we commonly see? What are the common pitfalls when caring for pregnant women? I've worked in critical access hospitals, suburban hospitals, and medical centers. And when an emergency happens to a pregnant woman, we tend to freak out a little bit. It's really, really hard to see that pregnant belly and to see the baby there that you in the field will have no ability to assess and no ability to take action on that baby's behalf. So we see paralysis in thought. The algorithms that are normally running through your head that you do so well are gone. We see misplaced attention, and while there's not a thing in the world you can do about that belly, your focus is on it. And we see folks that are sort of relaxed. They don't have an appreciation that the baby can be compromised while the mother appears stable. We see women flat on their backs with supine hypotensive syndrome, vital signs that have everyone worried. We see people who are afraid because of the populations with which you usually deal to provide adequate volume replacement. And we see people who, again, kind of hold back and there's delayed airway management. This is a CAT scan of a pregnant woman, kind of a treat. Not a lot of these available for viewing. You can see here definitively that those vessels are compressed by the heavy baby against the spine. 30% of the mom's blood volume can be pooled in her venous system. It can't get back up. The baby is in the way. And the blood return to her heart and to her brain is reduced. You know what that looks like. But the blood volume is also not returning to the placenta. And so, the baby can be compromised while the mother appears stable. What do? This is a pretty easy fix. Every time, every woman, every setting, you tilt the woman to get the heavy baby off those blood vessels. What else do? 3 things. You'll hear it over and over and over. IV access to provide volume, left side, and oxygen. Maternal resuscitation is the only means of fetal resuscitation. I love talking to this group because you know far more about the heart and far more about the cardiovascular system than I ever will. There are a lot of changes in the cardiovascular system in pregnancy. I've already mentioned that women have increased blood volume. They have increased cardiac output. We've talked about the aortal caval compression. And they have decreased peripheral resistance. What goes down to their legs does not come back up with ease. So what do you see in the field when you're attending to a pregnant woman? She may have an increased heart rate. We commonly see that when we do vital signs in the clinics. She will have a low blood pressure in the middle of pregnancy. Very normal to see somebody come in for a prenatal visit and in the middle of pregnancy have blood pressures like, 90/60. And you will see supine hypotensive syndrome until you take your action of tilting her off her back. Because she has so much extra blood volume circulating, she can tolerate blood loss. She will have increased skin temperature, can also throw you off while you're making an assessment, and she can have lower extremity edema. I like this picture, this original picture, which is actually not a woman, it's a sculpture, and a very accurate sculpture. She's raising her hands above her head. She is just trying to get some breath, because in pregnancy, she's taking in oxygen for herself and her baby. She has increased oxygen consumption. At the same time, her lungs just don't have the room to expand. So she has some decreased functional capacity. She has reduced oxygen reserves, and her diaphragm is elevated. So what happens if somebody needs more oxygen and their lungs have less space? They're going to breathe faster. So you'll see increased respiratory rate. You will see a decreased tolerance to hypoxia. In doing procedures, you have altered landmarks, and she has engorged capillaries in her passages, which means that any sort of procedure you do is likely to result in some bleeding. All normal. Musculoskeletal system. Probably you could tell me this one. You've all seen pregnant women walk. And what do you notice? Definitely the waddle. This is a life-size pelvis. When a woman is not pregnant, this pelvis is firm. When she is pregnant, she has laxity of ligaments, resulting in changes in gait. In this picture, you can appreciate the pressure that the baby places on both her back and on her pubic bone. So she'll have discomfort in back, hips, legs, knees, and that is not a sign of pathologic injury. That is normal. GI system. When women are pregnant, things sit in their stomach for a very, very long time. They have delayed gastric emptying. Their GI tract is just less mobile. It's more flaccid. Those wonderful hormones that keep the uterus calm and quiet also keep the intestines calm and quiet. Things just don't move through. You can appreciate from these pictures the stretching of the abdominal wall and the displacement of organs. So what does that mean to you in the field? This is a patient who is at increased risk for vomiting and aspiration. And to say that abdominal assessment is a challenge is an understatement. She also has a new organ that other people don't have. I always tell pregnant women, you should feel so proud of yourself. Not only are you growing a baby, but you're growing an entirely new organ. There are two sides to this. Things exchange at one cell layer. Oxygen comes in, waste goes out at one cell layer. The mom's blood volume circulates through this new organ about every 8 to 11 minutes. So do some really quick math and develop an appreciation for how quickly hemorrhage and blood loss can occur. So this new organ, what might that present you with that you would never see in a non-pregnant patient? Placental abruption is when the placenta breaks loose from the uterine wall. It is painful. That differentiates it from other placental trouble. Things that predispose to that are actually things that you may see. Drug use, trauma are two of the leading causes of abruption. Most abruptions, the cause is unknown. What we know from our last slide is that regardless of cause, blood loss can be profound and the results can be life-threatening. I think it's interesting to take a minute to look at these pictures, and you can see that sometimes when the placenta abrupts, you will have a gush of blood. Now again, this is an audience that I like to talk to. Like obstetrical folks, you are no strangers to volumes of blood. Obstetrical hemorrhage, however, can give you those moments that I talked about. You can have blood that comes out of the vagina with the force of a bathtub faucet. I'm looking at your eyes. I think you're developing an appreciation for obstetric hemorrhage. And some abruptions will present like that, but some are very, very sneaky. And the blood is in fact trapped behind the placenta, as you can see in these pictures, and not clear to you. You might just get a little tiny amount of blood that you see. Placenta previa is something else. That's a problem with implantation. In the very, very beginning of pregnancy, when the fertilized egg comes out of the fallopian tube and drops into the uterus, unfortunately, at times it drops low. And the placenta begins to grow right over the cervix, the only way out. You can see in this picture that there is no way the baby can come out. The placenta is in the way. This can cause profound hemorrhage, particularly in later pregnancy, when we start to have Braxton Hicks contractions, more forceful contractions, the cervix starts to open. The other reason we have bleeding with placenta previa is something goes in the vagina. Something pokes a hole in the placenta. So that gives us one of the golden rules of obstetrical care, which is if you don't know where the placenta is, never ever put anything in the vagina until you know. This is generally painless bleeding, and it helps you to sort that out from abruption. There are any number of causes for obstetric hemorrhage. Placenta previa and placental abruption are just two. At full term, the uterus is the size of a watermelon. It's out front. And when you have folks that have had blunt trauma, have been in a motor vehicle accident, it is possible that there will be a tear or a rent in the uterus, and that's called uterine rupture. What we'll talk about more today is obstetric hemorrhage after the baby comes out. Uterine atony, or relaxation of the muscles of the uterus, generally this size and tight when not pregnant, is the leading cause of postpartum hemorrhage. It is the cause in 90% of cases. So that recognition and management of OB hemorrhage can be really, really tricky. It's tricky because the mom will maintain her vital signs in the face of profound blood loss and then crash. Her hypervolemia, her increased blood volume, gives her a protective cushion so that she'll continue to give you blood pressure readings and pulse readings that are okay. At some point, she'll say to you, I just don't feel that well. I just don't feel that well. And she will enter profound shock. She can lose up to 30% of her circulating volume before she shows you signs. This is probably one of the greatest challenges to you, and it tells us that rapid deterioration can occur. If I ask EMS personnel what they're most worried about, so if I'm most worried about obstetric hemorrhage, what are EMS personnel most worried about? What they'll tell me is they're worried about prolapsed cord. That's a situation where the cord drops down below the baby's presenting part. The presenting part can be the baby's head, it could be the baby's feet, it could be the baby's buttocks. And you can see in this picture that if the cord comes down first and the baby is on top of it, it'll be compressed and circulation to the baby will be cut off. Now, pressure to the cord can be relieved in any number of ways. This is a good initial action to take. This is referred to in your protocols as knee-chest position. You will also hear people say, put her on all fours or put her on her hands and knees. You can think about that last picture where the baby was just sitting on the cord and imagine that if her butt were far up in the air and her chest were down low, that the baby would slide down and the pressure would be relieved. It's common sense, after looking at that picture, that to help the baby, all you need to do is lift the baby off the cord. Let the blood just flow freely through that cord. This is one time you'll notice in your protocols that you may insert a hand into the vagina to lift. And I think this is something that it's not learned. It's common sense. You put fingers in, you feel a baby part, you feel a cord, and you will feel it pulsing, and you just lift the baby off it. When we do this in the hospital, we actually keep our hand in there, run next to the stretcher to the cesarean section room, kneel down next to the operating table, have drapes put over us. We are under the drapes, and we are still holding the baby off the cord until the obstetrician makes the abdominal incision and lifts the baby out from the top. And I tell you that story because I think it really illustrates how do you manage a prolapse cord. No different in the field than it is in the hospital. One difference is that you have a difficult time moving people on hands and knees, and certainly you can't transport someone on their hands and knees. So that left lateral and deep Trendelenburg while lifting the fetal head or fetal buttocks off the cord is what you need to do. So, to review, when you get a call, think, look at this picture. This is only halfway through pregnancy. Imagine this baby going all the way up to the xiphoid process. Think about the displacement of those organs, all the alterations that happen in her anatomy and her physiology. Think about her response to shock that we just talked about. Think about the unique injuries that can occur. And think that you can only assess and take care of one of your patients. Triage of pregnant women is very challenging, even for the most experienced OB providers. We know that you will see a number of things before we see them. And you will have less ability to gather information to decide exactly what's going on here. So women will call you for problems that need evaluation, such as pain, nausea, vomiting, fever, anything that a non-pregnant woman can have, a pregnant woman can have. You will be called for suspected labor or rupture of membranes. Ruptured membranes is interesting. We spend a lot of time in the triage room figuring out if indeed membranes are ruptured. Many times they're not. Sometimes they are, and the baby delivers tomorrow. So we do not consider rupture of membranes without labor as an emergency. It takes some thought, it takes some evaluation. Suspected labor. Labor is one of the most difficult diagnoses to make. We certainly have diagnostic criteria for labor, but even those of us who do this every day know that we have sometimes at best a 50-50 chance of getting it right. It is a retrospective diagnosis. If the baby comes out, yes, I guess she was in labor. You will be called for imminent delivery, that we'll talk about. You will be called for obstetric hemorrhage. Before the baby is born, any amount of bleeding that she reports should be treated like an obstetric hemorrhage. You don't know whether this is a previa that's starting to break away and this little bleeding is just a sign of what's to come. You don't know if an abruption is starting to occur, and we have a saying that one bleed is a harbinger of another bleed. Prolapse cord we've talked about, and you'll be called to see patients who have experienced trauma. Well, EMS providers are very familiar with trauma care and the network that we have to take care of patients who have experienced trauma. I'm going to ask you today to think about that framework and apply it to pregnant women. So who do we transfer? We transfer folks who are in settings where the capabilities to care for them have been exceeded, where there's a lack of resources, and there are patient-specific factors. I consider pregnancy one. When always time sensitive, decide early. Once you have reached the limits of stabilization with a pregnant woman, she needs to go to a place that has the capabilities to care for her. We also have a keen understanding that we need to free up resources in our smaller communities and that we don't need to have folks do a complete workup or bring us the answer. We need you to bring us the patient, and we'll finish that workup. So match the patient's needs with resources early. How to get them there. This is where you all come in. No births in the air. There are plenty of stories about helicopters being unable to fly because of weather. Well, even in sunny, sunny weather, we cannot put a woman in a helicopter who is likely to deliver. So ground transportation is frequently used. Key fact is that OB hospitals need to be alerted to the incoming. This is not just something for the ED. Many OB units these days are staffed with sort of a small crew if no one's in labor. And they will need to call folks in, including possibly OR staff if they anticipate a cesarean birth. So early and communicate. Remembering the whole time that maternal resuscitation is the only means of fetal resuscitation. If you have mom on her left side, you know that you have blood flowing freely to the placenta. If you've given her volume, you know that the oxygen you're also giving her is carried. And so the real challenge is not what do you do when you pick her up. You just got here and you already know the three things you'll do. The real challenge these days is to determine your destination with a pregnant woman. And there is a challenging and changing OB landscape in northern New England. We have longer distances to travel. Our hospitals have shifting capabilities. And they shift not always in the long term, but sometimes in the short term. Some of our hospitals may not be able to take care of someone for a certain amount of time because their only OB provider is away. So how do you make those kinds of decisions? And what I would tell you is that you are not alone. This is an algorithm that we're working on. It is specific to the North Country of New Hampshire, but certainly as we work on it and perfect it, can be applied to other parts of the state. If she is pushing and you see no baby, it could be minutes till the baby comes out, or it could be hours. And so, in my mind, if you don't see the baby and you know potentially that this could be someone with an uncontrollable urge to push but is not going to have her baby, putting her on her left side, speaking to her calmly and in a reassuring way, having her do some slow breathing, and watching for rupture of membranes, poop, or a baby appearing are the crucial things to do. So you make the decision that an imminent delivery is about to occur. Now the fun begins. What's wrong with this picture? Absolutely, she is flat on her back. So the first thing you're going to do is you are going to position the mom. You are going to settle the room or the rig, and you are going to remember that panic is contagious. You will change the scene, even if this is the first baby you have ever seen being born, by moving with confidence, by being positive. If they say to you, have you ever done this before? You don't have to lie, but you could say something like, this is one of my favorite parts of my job. You want to have the mom be connected with you. Women in labor have about 12 inches, 12-inch surround in which they can hear. So you need to speak to her within 12 inches of her face and her ears. You need to make this setting as warm as possible, both physically warm for the baby who's about to come out of a probably 99-degree environment, and emotionally warm. I tell folks that unless you do this all the time, you need assigned roles, very rigid assigned roles. You need an above-the-waist person who is going to be communicating with the woman and her supporters and keeping the room settled, choreographing the room. And you need a below-the-waist person whose job it is to set up the delivery kit, watch the perineum, and do conduct of delivery. This can happen really fast, and my advice to you is slow it down. Many of you know what I'm talking about when I say go into the tunnel. If you are the below-the-waist person, you want to block out all the chaos in the room. You want to focus and you want to mentally slow things down. You also want to physically slow things down. The baby is going from a place where he or she has been compressed, has been squeezed, and we don't want babies that are like shot out of a cannon. We want babies that go from a place of compression to decompression gradually and gently. Words that are helpful for the above-the-waist person. Breathe the baby out, one hair at a time. Go, stop, go, stop, go, stop. If you keep your voice low in this situation, everyone else will become quiet to hear what you're saying. Birth videos in general are terrible ways to teach hand skills for delivery. You will see people's fingers every which way. Pressing here, a little carotid pressure, a little tracheal pressure, fingertips here. I'm going to teach you, when we use the birth trainer, always thumbs up. Thumbs up, your hands are on the side of the baby's head. You can do no harm. And I'm going to emphasize the use of traction. Traction is different than pulling. Traction with your thumbs up. In the thumbs up position, you are going to avoid twisting or bending the neck. And you're going to avoid all pressure. You know how when your adrenaline is really surging, you're pressing on things harder than you think, you're stronger than you think? This thumbs up is going to prevent you from putting pressure anywhere on the baby you shouldn't. And the other thing it does is it doesn't allow you to do a whole lot of head moving and bobbing. This is the perfect group to say, whichever way the baby is coming out, head first, feet first, butt first, your job is to keep the C-spine in alignment. Once the head is born, it goes really pretty fast. You use downward traction in your thumbs up position. The below the waist person is in the tunnel, watching carefully, paying attention, and you will both see and feel that anterior or top shoulder release. The minute you see that tiny little shoulder, you switch directions. You don't deliver the baby a long way out with it. Switch directions. Slow and easy, gentle traction. Once these shoulders are free, the baby flies out. And your job is simply to guide the baby out. Now you have two patients. Things to think about. There's a lot of wet stuff around. This baby's greatest risk is heat loss. So you want to throw that wet stuff aside. You want to dry the baby. You want to have a bulb syringe handy if you need it. Baby may need a little stimulation, a little rub on the back. And you may or you may not clamp the cord. Something that's familiar to you from PALS is the inverted pyramid. And while this isn't officially a part of the neonatal resuscitation program, I give it to you to use at this time. Love this picture. The baby is out. Baby is next to mom, who is at least 99 degrees. Around this neck of the woods, probably the hottest thing around. The baby is dried. The head is covered. Babies have a lot of heat loss through their head. There are warm, dry blankets on the baby. Baby is positioned close to mom's breast. That's really important. Nature has built in a safety mechanism for mom. When the baby is near her breast, even if the baby is not nursing, she will release oxytocin, a uterine contractor, from her posterior pituitary. And that will tighten her uterus. That will contract her uterus. And so your job now is ongoing assessment and also to just celebrate. Set up a little, hoop and holler. So what if the cord's around the neck? Is that an emergency? Is this emergency care? No. Cord around the neck is a common variation in births. Happens so frequently that people who catch babies for a living often forget to write it down. So what happens if you see that? You can slide it over the baby's head, as in this picture. Sometimes you can't even do that. The next contraction comes so quickly that the mom is pushing the baby out. And the baby will just deliver, all wrapped up in the cord. And we often will say, let me just take a minute to unwrap your baby. Your baby came gift wrapped. One question that often comes up is, what happens if the shoulders don't deliver? The head has come out nicely. You exert your downward traction in your thumbs up position so that you're looking for that shoulder to release, and it just doesn't. Well, try again. Take a breath. Try again. Pull the mom's knees right up till they touch her shoulders. So she's in a very exaggerated, almost squatting position. And in concert with her next contraction, have her cooperate with you. Have her push the baby while you exert traction. What if they still don't come? This picture shows an excellent technique, which is turning a mom over onto her hands and knees. People think, oh, she's in labor, how can she do that? I once had an experience in a city hospital on a narrow stretcher with shoulders that just would not deliver, and just bent down and said to the mom, I really need to have you do this for your baby. There is not a woman in the world, there's not a woman in the world who does not respond to that. Because women are in labor, it doesn't mean that they've lost their ability to understand what's going on. They need very clear instructions. We turned her over, and the shoulders came out. Placentas. I'm going to give you a little mnemonic to remember, little phrase to remember. Either way, it's okay. So if you're going to remember, thumbs up for how you hold the baby during delivery. Once the baby's out, either way, it's okay. The placenta may or may not deliver. We look for spontaneous delivery of the placenta. Never, ever manipulation, never, ever pulling. If the birth, the second stage of labor from full dilatation, the mom's 10 centimeters to the baby being outside, is the most risky time for the baby, this is the most risky time for the mother. Your job is not to worry about the placenta or doing anything with it. Your job is to watch for bleeding. How about cord cutting? Again, either way, it's okay. If the placenta delivers, you could wrap it up with the baby. If the placenta doesn't deliver, you could cut the cord. If the placenta delivers and is wrapped with the baby, you could cut the cord. It's okay. If you decide to cut the cord, and sometimes this has to do with logistics, there may be a short cord and the placenta is still inside and you really need to get the baby to a place of warmth on the mother. You may be in a physical setting where it's just easier to disconnect the baby for purposes of moving. Things to remember. Leave at least 6 inches of cord on the baby's side. If the baby were to run into problems and needed IV access, they have this wonderful access in the cord, nice big vessels, and they have these teeny weeny little vessels in their periphery. So you want to leave 6 inches of cord. You want to securely clamp the cord on both sides of the cut. You're going to cut in the middle. What you really want to make sure is that you milk that cord from one clamp to where you're going to place the other and put the second one on. The cord will blanch white. Can you imagine what will happen if you don't do that and you cut a cord that's full of blood? I guarantee it will hit the ceiling and everyone else in the room. You also, when you cut the cord, will want to shield the place that you're cutting to protect from blood spray. Now, baby's out. Let's presume cut off. Your job is to watch bleeding. Your job is to assess mom. And her uterus has gone from the size of a watermelon to the size of a cantaloupe. And this is the size. It's round. It's hard. It can't be indented. You can tell its shape as you feel this through her abdominal wall. Her bleeding is what we call bleeding like a normal period. Where is this? This is about 1 or 2 finger breaths below her belly button. Again, if you're not used to doing it, it takes a minute. Rest your hands on her belly, and you can feel for it. This is something that I would like everyone to feel and understand. This is exactly what the newly delivered uterus should be like. So, what if the newly delivered uterus feels like this? Kind of an elongated shape. You can dent it in. You're feeling through her belly. Get it in your hands, and boy, you can dent it in. When you look at her bleeding, she has brisk flow, maybe some spurts. This is what we call a boggy uterus. We call the top of the uterus the fundus. If you were to call into someone, they'd say, "Where's her fundus?" This is frequently above her belly button and displaced to one side. Anybody guess why it might be displaced? Full bladder will make this rise and tip to one side. The other thing is look at the difference in volume between these two. If the uterus is well contracted, there's no blood hanging around inside of it. If the uterus is boggy, it can fill up with blood. And my favorite teaching tool, the pot roast. After all, what is a pot roast? It's a muscle, and it's an atonic muscle. It has atony. There is 0 tone to this. About the same size, but mushy to the touch, difficult to outline. You couldn't say really what shape this is. You couldn't name a shape. And what you'll notice is that out of her vagina comes flowing blood. It may or may not have clots in it. Clots that are worrisome are larger than plums. They can become the size of grapefruits. And she may have spurts and gushes in between that. As part of your care for the woman who has bleeding, you'll note the amount. You will probably be wrong. Those of us that do this every day know that estimated blood loss in obstetrical situations is really, really hard to do. Postpartum hemorrhage is defined as blood loss greater than 500 cc's. Well, there can be blood way up under her back. Somebody may have taken out a chucks because there was baby stuff on there and poop and all kinds of things. So that if you are concerned about bleeding, you move automatically through your checklists. You find that fundus. Is it a cantaloupe? Is it a Nerf football? Or is it a pot roast? If it's a cantaloupe, she's stable, and you observe. If it's a Nerf football, she is at risk, and you continue to assess and take action. And if it is a pot roast, you take immediate action. And what are the tools that you have available? Fundal massage, rubbing the top of the uterus, makes those muscles just contract. IV access with the use of Pitocin if you are able, according to your protocols. Warm blankets, oxygen by mask. And very importantly, to save every chucks, every piece of linen, everything, and bring that to the hospital with you so that somebody else can do some estimation of blood loss. So where again is this fundus that I keep talking about? You can see the difference here. A firm round uterus will be right below her umbilicus. It will be 1 finger breadth or 2 below. The fundus that's at risk, that's boggy, that is filling up with blood, that's not controlling bleeding, because the uterus works in a very simple way. Blood vessels are clamped by muscle fibers. It is simply mechanical. That one will likely be above her belly button and displaced to one side or the left, one side or the other. And lastly, the mom who is at great risk for profound blood loss, that uterus just sinks low in the pelvis, little bit hard to find. So how do you do this fundal massage? Well, we like to say it's a lot like kneading bread. And you can do that and actually feel the uterus tighten under your fingers. You will feel it go from a pot roast to a cantaloupe. Now, depending on whether you're in a box ambulance that might have a center mount cot or a van ambulance where you have access only from one side, that will depend where you place your hands. But again, calm the environment. You always guard the uterus. One hand above her pubic bone, another hand on the uterus. Why is that? What could happen with that boggy uterus if you're pressing on it? Yeah, you could push it out, which is an obstetric catastrophe. So you want to have a hand right there. Feel this uterus turn to a cantaloupe right under your hands. I often prefer using my least dominant hand to guard and my more dominant hand to massage, but I've done it all ways and they all work. So another position for uterine massage is using the heel of your hand to guard the uterus. And you put that straight above the pubic bone. And you reach up and you massage from there. Once you have this uterus, a cantaloupe, the mom can actually take over for you. She hopefully will be having her baby close to the breast, getting some of her own Pitocin flowing. If the baby's eager to nurse, certainly could latch on and nurse. But she will get it. She's been touching this uterus her whole pregnancy, and she's always shocked to find it's down low and it's small. She's very comfortable doing that, and she can take over for you. And your job is then to transport mom and baby, warm and stable, to their destination hospital. So the purpose of this is for teaching technique, not for desensitizing you. And in fact, not having a live birth shown here allows you to focus on certain techniques. So my answer is a fewfold. Desensitize yourself by watching birth videos and learn your stuff. Your shock decreases when you know what you're doing. Your shock decreases when you move with confidence. That doesn't mean after an event like an imminent birth out in the field, well conducted, that you might feel a little emotionally overwhelmed, but that's after the fact. So the last thing I would say to you is to keep perspective and to remember that nature designed a system to work. We are at the top of the food chain. This is about survival of the fittest. This system works. If a baby has delivered with ease and that uterus worked well to send the baby out into the world, likely it's going to behave well afterward and it's going to be a cantaloupe. It's likely to work and to be well designed. And the other perspective is to remember what this is really all about. And that is that every time you attend a birth, regardless of setting, you are witnessing the birth of a human being, a person coming into the world for the first time, and you're witnessing the birth of a new family. And families come in all sorts of traditions and attitudes, and you will have whooping and hollering from some, and you'll have tears from others, and you'll have privacy with just a couple, and you'll have other families where there's grandma and grandpa and the dogs and the toddlers all around. Keep families together. Speak slowly and kindly during birth. After all, this is a birth. It is unlike other calls that you take, which are really, really bad things happening to people. And women and their families will remember this as a really, really good thing happening to their family. If you have conducted their birth in a respectful and a skilled way. Well, this program took some doing, and I would like to thank all the people that contributed to it. Suzanne Prentice, Vicki Flanagan, Brad Weilbrenner worked with me on this. Lots and lots of others. It was generously supported, and we're really appreciative from a federal Medicare Rural Hospital grant. This is a program that is initially targeted toward rural hospitals, but we've had interest from people who are not so rural. And Chip Cooper graciously took care of all the business with this.